This is Where We Live from Connecticut Public Radio. I'm Catherine Shen. The U.S. is facing a maternal mortality crisis. The women of color are bearing the brunt of it. Maternal mortality rates among American Indian and Alaska Native and Black women are 3 times higher than the rate for white women. That's according to Kaiser Health News. To understand those racial disparities, it could be worth looking at the past. Dr. Deirdre Cooper Owens is part of a growing group of historians examining the history of race and medicine in the U.S. In her book, Medical Bondage, Race, Gender, and the Origins of American Gynecology, she explores the early history of reproductive health care, where gynecologists exploited and performed experimental surgeries on enslaved women. Dr. Deirdre Cooper Owens joins us for the hour. She's also an associate professor of history at the University of Connecticut. Deirdre, welcome to the show today.
Thank you for having me.
And just a quick note to listeners that there will be some discussion of sexual abuse and medical trauma. And if you have any questions for our experts today, you can give us a call, 888-720-9677. That's 888-720-WNPR, or leave us a comment on Facebook and Twitter at Where We Live. So, Deirdre, before we get into your book, tell us a bit about your background, because you've described yourself as born to be an historian.
Yeah, so, I think as a child, I didn't think I would end up as a college professor or teaching history. I majored in broadcast journalism and thought I was going to be Oprah. However,
still can.
I still can. But hindsight is 20/20. And so when I think about my background, I grew up in a very small town in the Low Country in South Carolina, and my family are Gullah Geechee people. And my grandfather would always tell stories. I mean, we would sit on the porch and listen to Granddaddy tell stories. And my mother also was the family genealogist, tracing our family back to its colonial roots in South Carolina. And so thinking about that, her background in science and my dad working at the National Archives for over 30 years, now that I think about it as a grown person, I'm like, oh my gosh, I guess I was destined to do this. And so I think I just kind of, fell into the right profession for me.
And what was it about the lives of enslaved people and history that you became interested in?
It was, I really think it was my grandfather's stories. He was born in 1911. His grandparents were enslaved. And so he would often share these stories. And enslaved people were often at the center of them. And so by the time I went to Bennett College, it's a HBCU for women in Greensboro, North Carolina, I knew I loved reading and learning about the past. Once again, I didn't think it was a viable career. I thought people taught high school,
right?
That kind of thing, or elementary school. But as I started to learn more when I got my master's degree, this was, the 1990s was the era of the kind of Black Book Club. And so you start to read all of these pieces of literature. The lives of Black women in slavery just kind of, it resonated in many ways. And so by the time I joined a doctoral program, I knew for sure I wanted to write about enslaved women.
And when you sort of had that discovery and realizing that this is something that you can do, when was that moment that you started to connect that intersection between the lives of enslaved people and also early medicine?
It was interesting. I will never forget. It was 2005. And I was taking a research seminar. It was the most boring research seminar in the world.
I'm happy for your honesty.
Oh, my God. It was about, no offense to people who study steam engines, but I was like, my God, I'm so tired of hearing about the scientific revolution in the steam engine. And so I keep thinking, how can I, put my interest there? I was preparing to MC a program, actually, with Gynecology and the late great Reverend James Lawson, civil rights icon. And I'm reading a book Gynecology and Beverly Guy Sheftel wrote called Gender Talk. And there were maybe 3 sentences. Number 1, about a guy named James Marion Sims, had never heard of him, and experimental surgeries that he performed on enslaved women in Alabama. And I remember calling my mother, who had a degree in science, was teaching at the time. So I said, Mother, had you ever heard of this? And she said, only Tuskegee. This is even before people knew about Henrietta Lacks. And something clicked. And I thought, oh my gosh, I don't think I know of anyone who's really discussing and researching the role of slavery and the development of certain kinds of medical branches. And so after that, it just, my interest just took off. And so it was, it was scary because you're also writing about people who don't leave written records. Enslaved people were legally made to remain illiterate. And so I had to be really creative, but it was something that I was dedicated to after that moment.
Well, and I mean, it's amazing how that spark happens because you really just don't know, right, when that moment happens. And you mentioned Dr. James Marion Sims, who I don't know if people are familiar with, and he's known as the father of gynecology. So tell us more about him and what do we know about his work?
Right. So James Marion Sims is also a South Carolina native, born in the upcountry, and received his medical degree from Jefferson College in Philadelphia. And so he begins to treat Black and white patients. Many slave-owning physicians did back then. That wasn't anything that was weird. But he had, I think, 2 cases, and one in particular where back then they would say Negro infant died. And so, a lot of folks stopped patronizing his business. So he moves out west to Alabama. And he has to build up his reputation and his business. And he is, once again, working with enslaved patients, white patients as well. And one day he discovers that he could possibly repair a vesico-vaginal fistula. And essentially, there is a fistula or hole in the upper vaginal area where incontinence happens because of a prolonged childbirth. And so he's looking at this enslaved woman, and he performs a vaginal examination, which is also pretty rare for the antebellum era. This is the 1840s. And then he says, you know what, I think I can repair this. And so, years later, he is known as the father of American gynecology. But he begins this experimentation, this kind of search for medical discovery on the bodies of enslaved women.
And the practices were pretty atrocious.
For the 21st century, I would say yes. Often I will get this question because people say, oh my gosh, Dr. Sims, he experimented on these women, he operated on them, and he didn't get informed consent. And I'm like, that didn't exist in the 1840s, right? I think it is jarring for modern audiences, but I have to put them back in the 19th century.
Right.
And so they're like, what? I don't understand. And I said, so this is the thing. Slavery was an economic labor force, and it built this nation's wealth. So for someone like Sims, you go to the owners and you say, you enter into a contract with them. You gain consent from the owners. And you say, essentially, I am going to repair these bodies so that the economic value for these women can increase. And I'll take on the cost myself. That was pretty common. And so essentially he's leasing their bodies to repair them through surgical means. And so he does so for a number of years. He gets anywhere from about 9 or so enslaved women. We only know the names of 3, Anarcha Betsy Lucy. And he commences to experimenting and trying to suture the hole or the fistula for a number of years.
And do we know if he did?
He did. He did. He was successful. But the thing is, you're not using anesthesia. There's also a reigning belief about Black people's bodies, but in particular, Black women don't experience pain, and so a part of what I've tried to do is to provide context, but also to dispel some myths. Right. And try to provide some accuracy. So folk will say, James Marion Sims came up with this idea. And I was like, no, he wasn't that brilliant. Right? He inherited this thinking from people who existed many, many years before. And so there had already been thinking across the Atlantic world that Black people were different, that, some people believe Black people were different species of human beings. And so if you have that quote unquote scientific belief that you're dealing with a different set of human beings, you're going to believe all kinds of things about them, right? That there are biological differences between Black and white people. And so he's operating from that background and that context.
Well, and I think the context is really important and the nuances of the time, like you mentioned. Of course, when we look back with our sort of contemporary lens, it's going to look very different, right? Yeah. And so I think with that in mind, with so much movement going forward since those times, how do you think these early medical practices have set the groundwork for doctor-patient relationships today, and especially when we're talking about racial disparities in medicine?
Yeah, so, it is sad for me. Oftentimes I'll read 17th, 18th, 19th century medical journals or case books, and often the patient blaming. I think about cases in the 19th century where Black women's bodies weren't healed or quote unquote cured or fixed, to use the language of the day. And it's, because they didn't stop engaging in sexual intercourse, even though we know sexual abuse was rampant during the era of slavery. The negative medical outcomes are almost always the patient's fault. Those kinds of things. Seeing Black people as different biologically. And, what is even sadder, when you look at some of the 21st century statistics that have come out, I always reference one from the University of Virginia, a 2016 study. Dr. Kara Hoffman published it, and it made a huge splash in the medical world and the public health world. But she surveyed medical residents at the University of Virginia's med school and found that overwhelmingly, in fact, over 65% of medical residents believe Black and white patients were biologically different, that Black people experience pain differently, meaning that they didn't experience it much at all, that Black people had thicker skin. 2 of the respondents believed that Black people were born with tails. And this is from 2016, so less than 10 years ago.
Wow. Did that shock you at all based on your research?
It did, because these are students, I think about it. I'm a university professor, and for 4 years before I came to the University of Connecticut, I directed a medical humanities program. So I think these are the students that I taught, and I know they're not getting it from their textbooks. They're not getting it from their professors. And so there's always this sense of you had to take a generalized test, the MCAT, to get into a high-ranking medical school. And so how do you just kind of let all of the information that you knew, that you studied for, you just let it go? And you have this investment in racism and anti-Blackness, but you've already taken an oath to do no harm. And that kind of thinking is harmful. So even before you touch someone, if you're guided by those kinds of beliefs, it's scary for me, because I then think, what is the investment? What do you get as someone, charged to care for another human being? What do you get from that kind of thinking? Particularly because the United States, for many, many decades, has remained the most dangerous place for Black women and birthing people to either be pregnant or to give birth. And so it is disappointing, but I'm a glass half full kind of person. And so I do believe that we can work to dismantle and change it.
Well, and I know you have a portion of your book that you want to share with us, but I want to ask, based on what you just mentioned too, when you found out about that data and learning about people's perspectives at the time, how did you process that, and how did those conversations go? In some ways, I think I disassociated. As a historian of slavery, I didn't go in expecting to read like happy stories. Sure.
I also have a chapter on Irish immigrant women, and it was interesting because I didn't know much, so I was kind of learning along the way about the Irish diaspora. Often those stories shocked me the most, because ostensibly these are people who look like the doctors operating on them, and yet many of those doctors, including Sims, are treating these women, they're mapping them with Blackness. And so they then become the kind of new minoritized group in the United States that receives this kind of debased treatment medically. And so those were some of the stories that were more shocking to me. And so what I did was I had to tap into joy. And so when I went home, I looked at happy things on TV. I got my PhD at UCLA, so my gift to myself was to rollerblade. If I finished, a significant amount of writing, I rollerbladed.
Well, I'm from LA, so that's the most LA thing I've heard.
Oh my God, that's what I did.
Well, I think joy is very important. We talk about this on the show often. Is joy is an important part of, I think, all storytelling when we're talking about something so challenging and difficult. And so, tell us about what you're about to read for us.
Sure. So I wanted to make a very explicit point. So my first paragraph in my book, the first sentence deals with revising a historical inaccuracy. I finished my book when I was still living in New York, and I would often go to the historical marker of James Marion Sims's Women's Hospital of the State of New York. And the historical marker said, this is the first hospital dedicated to women's health, founded in 1855. And I was like, no, it wasn't. In fact, James Marion Sims was pretty explicit in his memoir that the first hospital dedicated to women was the slave hospital in Alabama. And so I proudly wear the label of revisionist historian because I was revising an inaccuracy. And so I'll begin with that first paragraph. The first women's hospital in the United States was housed on a small slave farm in Mount Meigs, Alabama, a lumber town about 15 miles from Montgomery, a large slave trading center. From 1844 to 1849, Anarcha, Betsy Lucy, and about 9 other unidentified enslaved women and girls lived and worked together in the slave hospital that Dr. James Marion Sims founded for his training and for the surgical repair of his patients. He had his workers, probably enslaved, build the hospital for the treatment of enslaved women affected by vesicovaginal fistula, a common obstetrical condition that caused incontinence, and that was brought on by trauma and by the vaginal and anal tearing women suffered in childbirth. Years after he performed his pioneering work, all experimental, Sims achieved success and an internationally good reputation. He would later be known as the father of American gynecology. The women he operated on continued to perform the duties slaves were expected to complete. These bond women tended to the domestic needs of the Sims family, which included a sick child. They cooked, cleaned, stoked, and kept the fire burning during the winter, fetched well water, wiped sweaty brows and dried crying eyes, planted and picked vegetables and nursed their babies, all while serving at the same time as experimental patients. As Sims surgical nurses, they learned the fundamentals of gynecological surgery from arguably the most successful gynecologist of the 19th century. During the 5 years they lived on Sims' farm, they helped him birth a new field. It is no exaggeration to state that these enslaved women knew more about the repair of obstetrical fistula than most American doctors during the mid to late 1840s.
Thank you so much for sharing that story with us. My guest this hour is Dr. Deirdre Cooper Owens. She's an associate professor of history at the University of Connecticut and also author of Medical Bondage, Race, Gender, and the Origins of American Gynecology. Coming up next, how does early reproductive health practices inform what's happening in the present? Join the conversation, 888-720-9677, or find us on Facebook and Twitter at Where We Live. This is Where We Live from Connecticut Public Radio. I'm Catherine Shen. Dr. James Marion Sims was once known as the father of gynecology, but in recent years, there's been a reckoning with his legacy. In her book, Medical Bondage, Race, Gender, and the Origins of American Gynecology, Dr. Deirdre Cooper Owens describes how this early physician operated and experimented on enslaved women. So, how does this history show up in reproductive healthcare today? For that and more, we're back with Dr. Deirdre Cooper Owens, and also with us is Dr. Veronica Maria Pimentel. She's a maternal fetal medicine specialist and director of research at the OBGYN residency program at St. Francis Hospital. And she's also an associate professor of obstetrics and gynecology at the Frank H. Netter School of Medicine at Quinnipiac University. Dr. Pimentel, thank you so much for joining us today.
Good morning. Thank you for inviting me.
Of course, and for our listeners, if you have any questions, give us a call, 888-720-9677, or leave us a comment on Facebook and Twitter at Where We Live. So, Dr. Pimentel, you've been listening to the conversation. Is there anything that Deirdre said that stood out to you?
First, I should say that, in part what I do has been inspired by her scholarship. It's not a coincidence that we're here, although in some ways we did not know that both of us were going to be invited. But the work that I do is I always I do it through the lens of equity, because as I went through residency, fellowship, and then became an attendee in 2017, I saw how the disparity was affecting specifically women of color, but in particular Black women. And for me as a physician, I did not necessarily learn that Dr. Sims was the father of gynecology. It wasn't like people walking around telling me that. But as you walk the halls of almost any university, and that includes the University of Connecticut, where I did my medical degree, I'm a proud Husky, you could see that the images displayed were all of white men who resemble Sims. So it was ingrained in us that that's what gynecology, or that's what a physician is supposed to look like, correct? And then when you take these standardized tests, they will use race as a proxy for disease. For example, if you're talking about syphilis, it would be a Black man. That would be a 55-year-old Black man presents with blah, blah, blah. Or if we're talking about gonorrhea, chlamydia, it would be a 19-year-old Black woman, single mom. So there are all these stereotypes that are passed, and we learn these, and they change our brains one way or another. And often you don't question them because you got to get through what you got to get through in medicine.
Sure.
But then when you take a step back and you see how it affects lives, you start questioning them. And when I got to 2020, got to a point where I needed to question what was happening and felt that I needed to do something about it.
Well, and I want to get to that questioning process, but sort of rewinding a little bit in history. You were born in West Africa, the Cape Verde Islands. Describe your experience living there, because that's where you first got interested in pregnancy.
I have been fascinated by pregnancy since I was probably 3 feet tall. I found pregnant people very beautiful. I was fascinated by the transformation, what I perceived as to be the miracle, but I wanted to also know the science behind it. For me, I grew up in a community when you got pregnant and you had literally almost a village behind you. There was your mom, there was your sister, there was your friend. And a lot of these births at the time actually happened at home. I grew up a few steps from a hospital, but I was birthed on my mother's bed. And that experience of that community was very different than what I've experienced here in the U.S. And what I learned in Cape Verde Islands was that by taking care of the women, you took care of the family, and then you took care of society. So that's what got me into medicine, into obstetrics, because I felt that's where I could make the biggest impact, is by starting from the very beginning, which was pregnancy.
And do you remember or recall the moment that, and you mentioned in 2020 that you started to have these questions? Was there a moment that you were like, I need some answers here? Or was it sort of a progressive sort of type of a process?
I think for most of us, 2020 is a year that we're not going to forget. For me, I was pregnant with my second child. I was about to give birth to a Black boy in America, in a system that was very different. We are reckoning with our racial disparities in the U.S. And then there was the pandemic, facing a virus that I didn't really know what was going to happen to me if I caught it, because I was presenting to work every single day as an obstetrician, pregnant, taking care of pregnant people. And I really loved that the medical community was stepping up and speaking against medical racism, speaking against police brutality, and many people were kneeling. I kneeled as well, but I didn't think it was enough. And I felt like it was my job to go back and figure out, what are we doing in medicine? What else can we do? And that's when I started to do the research to learn more about the role that obstetrics has in medicine, the role of disparity, what has happened to our patients, what can we do better? And for a long time, I avoided Dr. Cooper Owens' book because I knew that I was going to have a visceral reaction to some of that information. And finally, I read it and I put it all together. And that led to a petition that I wrote to the American College of Obstetricians and Gynecology, asking them to acknowledge, to recognize the role of enslaved Black women in the development of the field of obstetric and gynecology, and how the past explains how we are in the present. That we did not get here in the setting where Black women are 3 times more likely to die from pregnancy complications compared to their white counterparts. We didn't get here in a vacuum. There's a history that explained this.
Well, and Deirdre, I want to ask too, especially with what Dr. Pimentel just shared with the mortality rate, as we shared earlier, and Dr. Pimentel just mentioned that we know that Black women have a significantly higher maternal mortality rate than white women. So how do you contextualize what we're seeing today in conjunction to what we have seen in the past?
You know, what is interesting in terms of the context is those 18th and 19th century doctors were very explicit about how they felt about Black people and white people, men and women. And they could be. You know, I have to remind my students who are sometimes taken aback. I said, this was a slave holding society. And so this notion of multiculturalism and equity, that doesn't exist in that world. And in fact, it's illegal to have those kinds of integrationist conversations. So the anti-Blackness was just kind of part and parcel of those societies. I think what is sad, you know, and I'll harken back to what I said in the earlier segment, is people's investment in having those same kinds of thoughts, right, that are centered in a kind of anti-Blackness or medical racism, particularly when the science bears out that those are fictions, right, that those are biological fictions. The fiction of biological race, you know, has been dispelled decades ago, you know, and so it is concerning for me as an educator about what we need to do collectively to teach more effective science. And I say that as someone who's a child of a retired science teacher, you know, in the public school system in South Carolina and Washington, D.C. What can we do to actually teach people to understand science more accurately?
And what kind of responses are you seeing to you know, at the present? You know,
it's great. I've spoken to some folk. You know, there's a medical journalist named Harriet Washington who wrote a book called Medical Apartheid. It was published in 2008, which is when I graduated with my PhD. And she talked about the really negative response that she received. Me, on the other hand, I think because some time passed, you know, my book came out in very late 2017. People have been so receptive from medical schools. Dr. Pimentel and I did work with ACOG. I'm a former ACOG research fellow. I've served as a historical consultant for Mount Sinai Hospital, who owns the James Marion Sims papers, helping to, you know, I've done work with colleges and nursing schools, helping to design curriculum, all of those kinds of things, and create learning modules. So it's been pretty positive, because I think you'd have to be a really cold, cruel person not to want to have, you know, pregnant women and their children thrive. You know, nobody wants to, it doesn't matter what the political spectrum is. I've not met anybody who's like, no, you should not be engaged in this kind of work, because then, you know, it presents you as someone who has no humanity, you know, so it's been positive.
Well, and then talking about the humanity and community, you know, Dr. Pimentel, before we go to break, I would love for you to tell us a little bit about the Hear Her campaign, because this seems to be empowering to the patient.
Yes, so the Hear Her campaign is a campaign started by the CDC, where they're sharing the message about the urgent warning signs that can prevent potentially pregnancy-related deaths. So there are a number of symptoms that women can, or pregnant people can feel, that they should seek help. That might be a severe headache, vision changes, a fever, swelling, trouble breathing, chest pain. Some of these are a little more obvious. Like if a woman is feeling chest pain, she's probably more likely to report that. But if you're feeling severe abdominal pain, you may not think about, for example, that might be preeclampsia, which is a disease of pregnancy. So the idea behind it is to tell you these are some of the warning signs that some of the things that you may be feeling that might be the warning signs of something bad to come. At the same time, they're sensitizing the public as well. Your significant other, your friend can know these signs and tell you, hey, you just told me that you're seeing flashing lights. That doesn't sound normal. And the CDC says if you feel that way, you should call your doctor. On the other hand, as a healthcare professional, either as a physician or as a nurse or the intake person in the emergency room, they also, if they know about this campaign and the person presents postpartum with vision changes, they might be more inclined to call the OBGYN to come and see that patient. So it's a way to sensitize not only the patient, to empower the patient, but to sensitize their significant others, as well as the medical community, which often starts from the entry person in the hospital and goes then all the way to the physician who may be evaluating the person.
So this is a resource that they can get when they're in the hospital.
Well, it's available through the CDC, and the Department of Public Health also have campaigns about that. But they have beautiful flyers where it lists the symptoms. And I think the medical community in part is still learning about it. I'm currently doing research in trying to figure out how pediatricians and family medicine providers can utilize this to also help the pregnant person, because often it might not be the OBGYN who sees the person postpartum.
Right.
As often it might be the pediatrician.
Well, thank you so much for sharing that with us. You've been listening to Dr. Veronica Maria Pimentel and Dr. Deirdre Cooper Owens. They'll both be staying with us. And a quick reminder for our listeners, you might know that with Connecticut Public, we're currently having our winter pledge drive. So when you consider your end of year giving, and if you enjoyed today's show, or if you rely on us for the independent news and information you hear every day, please consider a donation. You know, it means a lot to us and it means a lot to me to hear from our listeners. As you know, our funding isn't guaranteed. It depends on you. So please consider donations today. Visit ctpublic.org/donate. And here are two of my colleagues to tell you more. This is Where We Live from Connecticut Public Radio. I'm Catherine Shen. Today, we're talking about the history of obstetrics and gynecology and how that history has informed OBGYN medicine today. And I'm going to jump straight back to the conversation with Dr. Deirdre Cooper Owens, who's an associate professor of history at UConn, and also Dr. Veronica Maria Pimentel, who is also with St. Francis Hospital and a professor at Quinnipiac University. And just to start off this conversation, we're going to hear from two different voices. Back in September, we spoke to Alicia McGregor, who's an assistant professor of health policy and politics at the Harvard T.H. Chan School of Public Health. And here's what she has to say about maternal healthcare deserts.
We are seeing for at least the last 2 decades or so that hospital obstetric services are closing nationwide. So definitely not just a Connecticut phenomenon. And this is happening even as we face a maternal health crisis in the country, which is characterized by the U.S. having the highest maternal death rates of any wealthy nation and spending more than any other nation on healthcare by far. And as your previous guest just highlighted, unfortunately, adverse maternal health rates are concentrated among Black and Indigenous women and birthing people. Now, in the first decade of the 2000s, we know that more than 10% of hospital OB units closed nationwide. And as you mentioned, we're seeing steady rates of closure continue, with some states being more impacted than others. And closures are impacting both the most remote and isolated rural communities, as well as the most densely populated urban areas.
And last week, Connecticut Attorney General William Tong joined our talk show Wheelhouse here on Connecticut Public. And here's what he shared about the state of reproductive care and abortion access here in Connecticut.
Connecticut is the sovereign state of Connecticut. We're independent of other states, and that means we get to decide for ourselves how Connecticut wants to live, and we get to pass our own laws respecting, honoring, and protecting women, patients, doctors, nurses, reproductive health care, and the right to an abortion. I've been to Texas, by the way, Frankie. I've seen what very restrictive or basically bans on abortion looks like. I've been in a women's healthcare clinic that, just over 2 years ago was buzzing with patients and doctors and providing not just reproductive healthcare and abortion, but, everyday healthcare, mammography, OBGYN, everyday needs for people who couldn't get healthcare anywhere else. And now this place is closed, it's shuttered, it's boarded up, it's abandoned.
Dr. Pimentel, could you respond to what we just heard and tell us what are we seeing here in Connecticut?
Well, I do have to say that, my apologies. I have children, so I always have a cough. In Connecticut, there's definitely the talk about hospitals closing, and I'm not necessarily involved in those discussions, but I am able to provide resources to many of these hospitals as a maternal-fetal medicine. Thankfully, with having a regionalized healthcare system, or I'm able to provide care in places as far as Massachusetts. I'm also able to consult with my colleagues in smaller hospitals. And this is the beauty of telehealth. We can actually use the technology that we have to close some of that gap. That said, I cannot deliver a baby via telehealth. I cannot perform a cesarean delivery via telehealth.
Right.
But in comparison to some of the states like Alabama, Tennessee, and even the Carolinas, we are a high resource area in Connecticut. And I'm so thankful to be living in a state where doctors feel protected and we're able to provide the care to our patients. And we have excellent hospitals like St. Francis Hospital that are providing the care to our community.
And Deirdre, any thoughts on what we just heard?
Yeah. A part of my, when I give public speeches, I think the personal is very political. And so I often use myself. I graduated high school in 1990. In the poorest county in the state of South Carolina, that's Williamsburg County. It's also the blackest state in terms of the percentage of African Americans who live there. The maternity ward closed in 1990. It's never been reopened. And so, these maternal deserts have been something that I've been trying to amplify and highlight for a really long time. But I think Dr. Pimentel has a really good point. It's something that's structural. And so how do you, convince people, right, that these things are needed, particularly in towns where the populations are draining, people are leaving.
Right.
And so we have to be more creative. Telemedicine is one. I am attempting to form a collaborative effort with a cohort of Black OBGYNs, one of whom is my cousin, and they've created a telemedicine portal for patients, particularly to attend to this need. So, I am impacted by it because of where I'm from, but it is reassuring to live in a state that's ranked number one. It's amongst the top ranked states that at least can protect expectant people.
So we've got a couple minutes here left, but Dr. Pimentel, I'd like to ask you, whenever we have topics on healthcare, oftentimes the big question is patients don't know what questions to ask or how to advocate for themselves. So what would you like our listeners to take away from this conversation? What can they do when they don't know how to articulate what they're feeling?
The biggest thing is finding out what's normal and what's not normal. And part of it is talking to people who have gone through pregnancies. Yes, they may tell you something that may not quite be true, because often we have myths that we pass along, but you learn so much by talking to your mom, by talking to your auntie. Then come with a list of questions and talk to your OB. Attend prenatal classes. Those are available in most hospitals and community centers as well, and other community places. Just know what is normal, what's abnormal. And then don't be afraid to speak up, and bring also a significant other, someone who is your partner, who's your advocate, who's listening with you, who may ask the question that you forgot or the question that you are afraid to ask.
So bring a friend, essentially, if you need or want one. Correct. To the doctor's office. Okay, I think that's a lot of people need emotional support when they do that. We got about a minute here, but Deirdre, any final thoughts you want to share with our listeners?
Yeah, I would echo what Dr. Pimentel said. I'm a big advocate for having doulas or patient navigators that can help more reticent patients, who are afraid to advocate for themselves, who can advocate for them in more formal ways, and just always have community around you if you can.
So a little echo between the two of you. Are you seeing more people use doulas? Because that's something that we wanted to get to, but running out of time.
Yes.
So you are seeing an increase.
I am.
And in Connecticut and both like
in Connecticut and nationwide, I have to say. So that is, that makes this girl half, the glass half full kind of gal, very happy to see the growing number of doulas in cities and also in more rural areas as well.
And do you think there's a reason why people are going more towards that?
I think particularly for mothers of color, birthing people of color, they are reading the stats, they're afraid. And so they tend to want to put a bit more trust. I kind of call it a intercessory person who can intercede on their behalf. And so it's a way of advocacy for themselves and autonomy.
Well, thank you so much for that. You've been listening to Dr. Deirdre Cooper Owens, who is an associate professor at UConn and also author of Medical Bondage, Race, Gender, and the Origins of American Gynecology. Thank you so much for your time today, Deirdre.
Thank you.
And also with us was Dr. Veronica Maria Pimentel, who is a part of the OBGYN residency program at St. Francis Hospital. Dr. Pimentel, thank you so much for being on Where We Live.
My pleasure.
I'm Catherine Shen. Today's show is produced by Tess Terrible. Our technical producer is Dylan Reyes. And it is our December fund drive. Consider supporting Where We Live and all of your favorite programming during our donation pledge drive. If you rely on the independent news and information you hear every day on Connecticut Public, please consider a donation. My colleagues and myself are working very hard to get the storytelling to you. And our funding isn't guaranteed, so we will appreciate any amount is no big or too small. We appreciate your generosity either way. And you're going to hear more about it on how to do that from two of my colleagues.